Hello, this is Dr. Bhomik. Today I'm going to discuss peripheral precocious puberty. In my last lecture, I did discuss the true precocious puberty, and today I'm going to discuss peripheral precocious puberty. And this condition is divided, I like to divide it in two parts. One is concerning, and there is a significant etiology. As a result, they should be identified and as soon as the diagnosis is made should be referred to the pediatric endocrinologist. I like to divide them in two parts. One is virilizing condition in males, another is feminizing condition in females. So virilizing condition of the male, the most important one will be congenital adrenal hyperplasia, both 21 hydroxylase and 11 hydroxylase deficiency. Although with the neonatal screening program, we detect this um, much earlier, newborn period, but there are situations where they are partial enzyme deficiency and late onset, therefore they can escape the neonatal screening program. And second is the androgen secreting tumor. A testicular disorder like what we call familial testotoxicosis is also known as gonadotropin independent sexual precocity, McQueen-Albright syndrome, and HCG secreting tumor. I will just discuss the one which is important for you to know and also a favorite board questions. Feminizing condition in females, again it could be adrenal disorders, a tumor which is producing predominantly the estrogen, and the ovarian disorder could be the ovarian cyst, granulosa and thicker cell tumor, again that produces estrogen. McQueen-Albright syndrome here also important, and not to forget some of the environmental factor, environmental contamination, or that could be in the food additives, it could be in oil or shampoo. Just lavender oil is pretty well known, and the shampoos that contain estrogen. And oral contraceptive pills is accidental or the chronic ingestion of that will definitely will give that kind of problem, and HCG secreting tumor. Peripheral precocious puberty and central precocious puberty, these are the two different things. And what is the difference between peripheral and central? Central precocious puberty, as I have discussed before, is mediated through hypothalamic pituitary gonadal axis. And in peripheral precocious puberty, it is not. It is not activated through hypothalamic pituitary gonadal axis. Therefore, if you estimate the hormone level for FSH or LH and they will be suppressed, will be at prepubertal level. And there is one test we do called GnRH stimulation test, and normally in true precocious puberty there is a significant rise of LH, which is rather diagnostic. However, in this condition you will not see that kind of response, is rather will be flat. Since this is isosexual, that means the boys look like boys and develop as boys, and the female develop as female. So testosterone in the boys will be elevated, and estradiol level in the girls will also be elevated. So this slide that I'm going to show you, that is somehow or other, as I said, is very board question favorite. And the way to remember is that McCune-Albright syndrome, triple P of McCune-Albright syndrome. P for precocious puberty, another P for polyostotic fibrous dysplasia, and another P is for pigmentation, which is known as cafe-au-lait spot with irregular border. The other thing also can happen with this condition is that excessive production of autonomous growth hormone, hyperthyroidism, and Cushing syndrome. Although they don't have to be present, but that can happen. And this is caused by the activating mutation of alpha subunit of G protein, and therefore persistent activation of cyclical AMP, and that will drive the process. This is a very nice diagram of of cafe-au-lait spot pigmentation, and this is a patient with McCune-Albright syndrome. And the other one that I told you about, polyostotic fibrous dysplasia, the fibrosis of the bone, for this could be in the long bone, but skull, this patient has got a very thickening. This is called polyostotic fibrous dysplasia, which is seen consistently with the patient with McCune-Albright syndrome. Then the next one is gonadotropin independent precocious puberty, which in the beginning we knew as familial testotoxicosis. This affects the male, is a X-linked dominant, X-linked somal dominant. However, new activation or de novo can also occur. So it's affect the boys, and it usually manifested before the age of 4, 3 or 2, early on, less than 4 years of age. And one of the things that we see in this condition is bone age is advanced since testosterone level is high, and this is the ludixal hyperplasia, so the testicular enlargement will be also seen by physical examination, and gonadotropin FSH is suppressed. And as I mentioned, it is activating mutation of G receptor, and over the period of time, this patient will develop true precocious puberty because testosterone will advance the bone age, and once the bone age is advanced, hypothalamic pituitary gonadal axis is going to be activated because they listen to the bone maturation, not the chronological age. Very sim, and this is one a patient of mine, and this is testicular biopsy was done, and you can see some pubic hair, and this is a 3 years old boy. The McCune-Albright syndrome, as I mentioned before, will also have advanced bone age, and they also ultimately develop true precocious puberty. And this is one very unique condition, chronic primary hypothyroidism, and in some cases, persistent chronic primary hypothyroidism may indeed give the premature thelarche, and the usual findings in these cases are very high TSH level with hypothyroidism. TSH occupy the FSH receptor. Since this is glycoprotein hormone, FSH, LH, TSH, and HCG, they are all glycoprotein hormone, and they have a same alpha subunit only there is difference in beta subunit by by one amino acid. So this is called a specificity spillover or cross. TSIs occupy the FSH receptor, and there could be a high prolactin level, and occasionally there could be galacturia as well. Testicular enlargement seen in the boys and breast development in the girl is also seen. However, the characteristic finding, these patients do not have advanced bone age. As you know, thyroid hormone is very important hormone for the advancement of the bone age or progression of the bone age. Since the thyroid is low, so even then they may have the uh, testicular enlargement, ovarian enlargement, and breast development. The key here is that if you do the bone age, it will not be advanced, and obviously thyroid function is going to give you the clue. The changes in the ovary that one has seen is kind of polycystic ovarian finding, and as soon as you start them on thyroxine, and as soon as the patient thyroid level comes back to normality in months or so, it will the thelarchy will reverse back to normal. And this is a 4-year-old girl. Again, as you can see, the breast development, but nothing much. And this is important to remember. Now I'm going to go to an area what we call incomplete precocity, and this is something any pediatrician who is in private practice or any working in the clinic, they are going to see it. And this is very common than what I have discussed previously. And in this condition, there are two conditions I'm going to discuss with you briefly. The one is premature thelarchy, and the other was premature adrenarchy. Premature thelarchy is the breast development before puberty. However, in this situation, in general, the breast development occurs less than 2 to 3 years of age, and it is self-limited, and it could be unilateral or it could be bilateral as well. The one of the distinction by physical examination, one would see that papillae and the areola remain underdeveloped. Areola remain underdeveloped, as opposed to the true thelarchy, which is mediated through the estrogen. It will not be underdeveloped, and there will be you will see it will just like a normal physiological breast development. And it is not actually associated with growth spurt, or there is no significant advancement of the bone age or any estrogenic effect on vaginal epithelium. So no estrogenic effect on vaginal epithelium. And there are various causes of the premature thelarchy, and that I will share with you as I go to the next slide. And this is infantile. Many pediatricians have seen it, and this in the newborn period, as you can see, there is a significant breast enlargement, but what you see, the depression right here. So there is no areola is depressed here, and that's not what you see in true precocious puberty. It will be equally elevated, and this is because of the maternal estrogen. And pediatricians also know that there are few babies, they may have even vaginal bleeding, what we call mini period. Nothing to be done, and it should be observed, and over the period of time is going to resolve. So what is the etiology of thelarchy beyond infancy? Well, exactly is the cause is not known, but it could be a transient estrogen secreting ovarian cyst, and in the diet could be phytoestrogen, lavender oil application, and some herbal medicine and OCP. The transient ovarian cyst is interesting because the finding will be now you see and now you don't. So there will be an intermittent increase of the size of the breast, and which correlate with the development of ovarian cyst. Once the cyst is ruptured and the breast development is remitted, and transient activation of hypothalamic pituitary ovarian axis. But in other words, there are a lot of possibilities, but exact etiology are known. But this is a benign condition most of the time. If you do the hormone profile when the patient comes to your office, actually majority of the pediatric endocrinologists, by doing a very good examination, and may not like to do anything in the first visit. Then follow-up is extremely important. Follow-up every 4 to 6 months. And over the period of time, if it does not regress or go away, then some test will be necessary to make sure that you are not missing anything significant. And again, FSH LH will be prepubertal, but if you do a GnRH stimulation test, and sometime you will see the increase of FSH level, not the LH, FSH level. No other pubertal development, menarche occurs in time. Close follow-up is necessary to rule out development of precocious puberty. I have seen 2 cases whom I was following them had all characteristic features as well as the biochemical hormonal finding of premature thelarchy, but over the period of few years they indeed develop precocious puberty. So that's why follow-up is extremely important. I have also seen some of them will continue to have a small degree of thelarchy, will never go away, and then when the patient will start going through the normal developmental process, and then they will develop thelarchy. And so that has been also seen. What about premature adrenarche? By definition, again, the pubic hair development before its time, less than 8 years in girls and about 9 years in boys. But a typical patient with premature adrenarche is like this. By far the majority of the patient will be female, and African American has somewhat higher incidence than the Caucasian, and they usually present with nothing but pubic hair. Pubic hair is distributed mostly along the labial border, and there will be no enlargement of clitoris, no estrogenic effect on vaginal epithelium. They may have some hair in the axilla, and apocrine type of body odor has been also seen. And many of these children are overweight. Many of the children are overweight, and no pubertal growth spurt, Bone age is minimally advanced, but not significant minimally advanced. Once measure hormone profile, you see FSH, LH, these are all going to be prepubertal, and plasma DACS, dihydroepiandrosterone sulfate concentration, correspond with the Tanner staging of the breast development, staging of pubic hair development. So therefore DACS, so that some endocrinologists like to call them puberty of the adrenal gland, because as you know DACS 90% and above come from the adrenal gland. So what is most important is not the pubic hair development here, but since majority of this patient is also overweight, they are very likely or high risk, I would rather say high risk of developing type 2 diabetes, polycystic ovarian disease. And therefore, it is very important to make sure the family given the counseling in line of losing weight, and also like to make sure that they have no secondary causes. Though weight management, as I said, is very important, and this condition not always the way I said in the puberty of the adrenal gland, but this could be also be secondary to 3 beta hydroxysteroid dehydrogenase deficiency, which is partial, and other feminizing endocrine tumor or virilizing endocrine tumor should be ruled out.